Good afternoon, everyone, and welcome. I see people are coming in from the waiting room quickly. I'm Catherine Peers. I'm Chief Operating Officer for the NTG, and just want to very quickly welcome you today. As people are coming on, I'm going to go over just a few very quick housekeeping slides for you, and then we'll get started with our content. So regards housekeeping, we are recording the webinar. The link will be sent out to everyone who is registered within 48 hours of the end of the webinar. You are all muted by default, and your video is turned off. So shouldn't be a problem with that. If you do have questions, getting to the next point about chat and Q&A, if you have questions, put your questions in the Q&A box, please. Please reserve the chat box for technical questions. So questions about content in the Q&A box. Technical questions should go in the chat box. If you do have questions and we need you to elaborate on your question, we may ask you to unmute yourself at that point, but again, everyone is muted by default as we get started. We are going to be watching that chat box, and we'll be turning to those questions at the end of all the presentations. And those of you who are looking for continuing medical education credits, those will be available to you at the end of the webinar. You do need to attend the full duration of the webinar, and there is a survey you will need to complete to get those CMEs. There'll be more information on that at the end, along with the link to the survey, which you will need to complete for your CMEs. This is a link to the handouts for today. They should have come in your reminder email that went out an hour before the webinar. I will put this in the chat box, or I'll attempt to. I'm moving slides, so maybe I won't be able to. But you will also, along with the link to the recording, get a link to download the handouts if you would also like those. And very, very quickly, just about the NTG. The NTG is a wealth of information on all things IDD and dementia. We invite you to visit our website. We have all sorts of publications and events that go on. So we would really encourage you to view the website if you haven't already and you're not already familiar with it. I think you'll find lots of very helpful information there. And if you have questions and you can't find something specifically, there is a little box that says something to the effect of contact me, and you can put your question in. It will come through and we will answer your question and try and direct you to whatever it is you're looking for. We also have an online monthly support group. And again, please, if you haven't already visited our website, please just take a few minutes at some point and check it out. With that, I am going to turn it over to Dr. Keller, who is going to introduce today's speakers. So
thank you. Yeah, thank you, Catherine. I'm just so thrilled and excited for today's presentation, and Catherine, very much for opening this up. We have a great, amazing speakers today, and you're going to hear them in a moment here. Bo Ansis, Margot Rondeau, Emily Largent, and Brian Chicoine. And many of you who are on the call may know of these individuals, because these are really a wealth of information from different areas in the IDD, dementia, aging sector. And you're going to really hear just really updates in what we're going to talk about. I'm Seth Keller. I'm the co-president of the National Task Group. And our colleague Lucy Ezralou is going to be the moderator, and you're going to hear going back and forth and all this information for our colleagues. And just to let you know, we're going to have many people that are going to attend from all around the world. There's such a vast amount of interest that really you're going to hear about this, and this will be recorded. I don't want to spend too much time giving myself all the voice here, so I'm just going to stop right here and just let our speakers kind of start. So let's begin the show. Who's up next?
I'm up and bat next. Thank you.
There you go.
So thank you, Dr. Keller. So here we are at the second NTG-sponsored biomarker update. Hard to believe the first one that we held was on October 7th of 2021, 4 years ago. And there's a lot that's happened in the field since then. So we'll have the opportunity over the next hour and change until 6:30 Eastern Time to hear medical, family, and bioethical perspectives on this important topic. And so, as Catherine had previously said, please put questions at any time in the Q&A. We're lucky to have Kathy Service, who's the co-chair with me of the Applied Research and Clinical Health Subcommittee of NTG, to be reviewing the Q&A, which we will get to after our last speaker, Dr. Chacoin, we'll have a little discussion among the panelists, a prompted discussion, and then we are going to go to the questions from the participants. So thank you. And Dr. Ansis, you can take it away.
Thank you, Lucy. It's really a pleasure, and thanks to everybody for joining in today, if it's the morning, evening, or afternoon at where you're located. So I'm a neurologist here at Washington University, and I'm going to be talking about transition of care for Alzheimer's disease and Down syndrome, biomarkers and therapeutics. If we go to the next slide. So we know that Down syndrome is the most common chromosomal disorder. As you can see, for our colleagues throughout the world, 6 million are with Down syndrome and 250,000 in the United States. Typically, it's the copy of 3 copies of that, so that's that full triplication. But in some cases, there can be parts of it, either this translocation or mosaicism. If we go to the next slide, what's really happened, and especially even in the last couple of years, is that the life expectancy for individuals with Down syndrome has greatly increased. And you can see on that kind of 2 hash lines, that is the general population, the top one being females, then the line below it, males, and then the solid line is those individuals with Down syndrome. And you can see even those in the 1970s, the average life expectancies was about 30 years of age. And now in 2020, it's an average of 58 years. So we've had significant improvements for many of the comorbidities, have been greatly controlled. And because of that, so many people are living much more productive lives. We can just look at Chris Nickick or others that are in the community that are doing amazing things. If you go to the next slide. But that's led to some really gaps that are in the field, and Dr. Chacoin and others, Emily Largen and others are going to be talking about some of these other topics, is that there are several child DS clinics, but there are very few adult DS clinics. And this transition and handoffs or ways to kind of transition patients, it's very tough. And what we're kind of thinking about is that this needs to take over a number of years. And we really need adult clinics that are multidisciplinary, that cover multiple different fields. And we really need to be starting to think about that, because we need to educate both the family as well as the community, but we need to do it on ourselves, meaning that those that are providers, we need to have more courses and discussions with medical students, residents, and even senior clinicians, because we're not really taught enough about Down syndrome in school, and we really need to kind of bridge those gaps. We also need to be thinking about housing opportunities for many of these individuals, because as we're seeing now, they are now outliving their parents. And then with changes that we're seeing here in the United States, what kind of care can be provided to these individuals? So if we go to the next slide. So this clinical diagnosis of Alzheimer's disease, it's not always easy in individuals with Down syndrome. You can see that the average of time between first symptoms and then when an individual develops the disease is pretty short, within 8 years, versus what we see in Alzheimer's disease, which is in late onset, which is about 12 to 15 years. And yes, we do see these memory issues, disorientation, sometimes confusion, but it can be other areas. And so when I'm seeing patients and when other colleagues of mine, we're seeing these individuals, it can be changes in their behavior, disorientation, changes in sleep pattern, forgetfulness, and even withdrawal. And so some of these kinds of signs and symptoms, we got to really be on the lookout for. If you go to the next slide. And then our ways for evaluating these individuals can be very different. And so we often do thyroid testing, other kinds of laboratory testing to rule out some issues. And then if it does, we can kind of start, and by thinking about it and at certain ages, that's when Alzheimer's disease kind of comes out to the forefront of our diagnosis. Now, this understanding of this link between Alzheimer's disease and Down syndrome has been known since the 1940s, and it was really a pathology study. So when we looked at the brains, we saw these pathological changes that we see in Alzheimer's disease in individuals with Down syndrome. And we know in general, the lifetime risk is about 90%. And you can see on that right-hand side of the figure, it's because of what makes individuals with Down syndrome so special. They have those 3 copies of the chromosome 21. On chromosome 21 is this thing called the amyloid precursor protein. That protein that makes this thing that we are all making, which is amyloid, but in Down syndrome, it's a lot more of that amyloid. And that amyloid kind of comes together and forms these almost balls, these amyloid plaques that then deposit within the brain. If you go to the next slide, and we can see that by pathology studies. So on the left-hand side, you can see that even at age 31, we're already starting to see these kinds of changes. By age 40, a lot more of those brown dots, aka that amyloid that's present. And then by age 54, you can see that the brain has large amounts of this amyloid. But it's not just this amyloid, it's also this other hallmark of the disease, something called tau, that we are also able to see on these pathological studies. And what we now know is that on pathology, by the age of 40, most individuals with Down syndrome already have those pathological changes. That means they may not have those clinical signs yet. They may be in this preclinical stage, meaning that they have some of the pathology but are not showing the overt signs, but they're on a trajectory to developing Alzheimer's disease. So if we go to the next slide. So we've kind of come up with these hypothesized curves. So these ways of when are these changes kind of occurring. And really, it's only been in the last 5 years where we've really started to really test out these kinds of ideas that are occurring. And so you can see that even at the age of 20 and 30, there's this amyloid changes. We then propose that there are then these changes in tau, this other hallmark, and then these cognitive changes. Now, only in the last 10 to, well, maybe 15 years have we had ways to actually look at this amyloid and tau within the brain without actually doing biopsies or an autopsy, but we can look at it in vivo, meaning in a living individual. So if we go to the next slide. So, we go back. This is one form of Alzheimer's disease, and there's another genetic form, which is called autosomal dominant, which is another cause that also leads to Alzheimer's disease. And what we've been very interested in doing is comparing and contrasting these 2 forms of Alzheimer's disease, because we do have some treatments for this autosomal dominant Alzheimer's disease, and we're thinking that if they would translate, they may actually help in Down syndrome, as well as may even translate to the more common form, this late onset Alzheimer's disease. So if you go to the next slide. So if we're going to hit some buttons, so if you hit the first button, if you'd be so kind. So hit another button. I don't know if the graphics are coming up. Okay, maybe they're not. All right. Oh, there they go. We'll hold it right there. That's perfect. So what we're looking at on the left-hand side is these curves that we think are these changes that are occurring. And we're putting in that solid hash line that's going up and down. And we're saying that's when we think the onset of the disease is occurring. And on the left-hand side is Down syndrome. On the right-hand side is this autosomal dominant. What you start to see in those kind of aqua colors, there are already changes 20 years before an individual becomes symptomatic, meaning that there are already these changes in amyloid that are starting to accumulate in these individuals 20 years before they become symptomatic. In green are those other changes in that tau, meaning that other marker that we think is the hallmark of the disease. You can see again with that solid line through using some imaging techniques, something called a PET scan, a positron emission tomography. There's this increase in tau that's also present, and that's also seen in the autosomal dominant. If you hit the next button, then we can also see other changes in neurodegeneration, meaning shrinkage of the brain that's also occurring, and they're occurring a little bit later in Down syndrome. And then if you hit the final one, which is going to be in red, there are these cognitive changes. And so when an individual is developing Alzheimer's disease, it's not just one day they didn't have it and the next day they did. It's a slowly progressive process. We see this both in Down syndrome and autosomal dominant. But the difference is, and we'll show you this, is that it's a lot more sped up process. And what I would kind of say is that Down syndrome is like Alzheimer's disease on steroids. So if we go to the next slide. Here you can see that where we're looking at this amyloid within these individuals, and you can see these plots at different ages and using different cutoffs. The point of this is that as individuals with Down syndrome are getting older, we can already measure this with these PET imaging techniques, and it's rising by the age of 40. And by 50 and 60, you see most of those individuals have large amounts of amyloid that's present. If you go to the next slide. And when we did these kinds of comparisons with this autosomal dominant in our lab and comparing that to the Down syndrome, you can see those A, meaning asymptomatic Down syndrome, they already have higher levels than their sibling controls. So their brothers or sisters who do not have Down syndrome, there are already elevations in this, and by the time they become that SDS, meaning become symptomatic, meaning having significant cognitive impairment, there's even a greater rise in this amount of amyloid that's present. We go to the next slide. And when we looked at those timeframes, because those were hypothesized timeframes, it occurs about 17 to 20 years before an individual becomes symptomatic with the disease. If we go to the next slide, it's not just that, we can also do another way to evaluate it. So as I was saying to you before, there's one way called a PET scan where we inject, wait a period of time, and then see if there's uptake. Another way that really helps us sample what's going on is a very simple and very safe procedure, is something called a lumbar puncture. And in the lumbar puncture, what we're doing is taking some of that spinal fluid that's surrounding the brain and then looking for these amyloid changes. And you can see, because if there's more depositing in the brain, there's less in the fluid. So we see this drop in these spinal fluid values in those individuals that have Down syndrome as they're progressing with the disease. And so this is another way for us to make a diagnosis as well as evaluate potential therapies. If we go to the next slide. We can also look at how that tau changes in the brain. And what we do is when we compare these two different diseases, it spreads very quickly throughout the brain. And it starts primarily where that red and those purple are, meaning in the back part of the brain, and starts spreading to the front part of the brain. And so what we're seeing is that this nicely looks like what we see in late onset Alzheimer's disease, but in a much shorter time course. And if you go to the next slide, we can see that by looking at these plots. So when does the amyloid change and when does the tau change? In typical late onset Alzheimer's disease, it's about a 10 to 15 year window. In this autosomal dominant, it's 7 years, but it's only 2 years to 4 years in Down syndrome. So again, it's a much more sped up process. It is a process where there's that excess amount of amyloid, but it is also other features like this tau, other changes that are also occurring in the brain. We didn't know this 5 years ago. This is all new information because people have been able to participate in studies and we've been able to follow them and see these kinds of changes. If we go to the next slide. It's not just that, it's also a loss or a shrinkage of the brain. If we go to that bottom right-hand figure, you can see where the green is, which is where all the changes in Down syndrome. It's a lot of part of the brain. The white is where there's overlap between these two diseases. And then the red is where it's just in autosomal dominant. This tells you again that this is a diffuse, meaning it's spreading throughout the brain and there's shrinkage throughout the brain. If we go to the next slide. So what do we have and how have we been able to generate some of these kinds of data and be able to present it to you as well as inform the field? There is something called the Alzheimer's Biomarker Consortium for Down syndrome. It is studying individuals 25 and up and is looking at some of these markers. It's also looking at genetic factors and is really trying to get individuals ready for, I can't believe I'm saying this, clinical trials, which we're actually now starting to conduct. So if you go to the next slide, this is where it's located in the United States. You can see we are in all over the United States. There's some in the West Coast. There are a couple of us in the Midwest, and then there's a fair number of people that are actually on the East Coast that are doing these kinds of studies. These are the different locations that are doing this kind of work. You can see in the green is where we're located here in the center of the US that's doing some of this important work. If you go to the next slide. Because of that, we're characterizing these individuals and we're getting them ready for this trial-ready cohort for Down syndrome. And you can see that it's some being fed from this Alzheimer's biomarker consortium for Down syndrome. Some are being directly recruited, and there's also a registry. And so we now have these individuals that are well characterized, and now we're starting different clinical trials. And I'll walk you through some of these different clinical trials that are out there. And this is not just in the United States, but for our European colleagues, you can see a couple of the sites for the track DS that are also available as well. We go to the next slide. And so one of the different ways is, as I showed you in that picture before, there's a large amount of increase in production of the amyloid. So can we work at ways that can kind of reduce that? And that is something called an antisense oligonucleotide, meaning that it prevents the protein from kind of being made, or we can kind of take down or suck out that amyloid that's present. So we can either do that through a vaccine, or we can do it through something called a monoclonal antibody. It's things that end with MAB that you may see in those kinds of commercials. And that's the same kind of therapy that we're doing actually in late onset Alzheimer's disease. And so what I'm really excited to tell you is that we're now finally conducting those kinds of clinical trials. They did not exist even 3 years ago or 2 years ago. They've really only recently started. So if you go to the next slide, the first study that's being done that is active right now is a vaccination. And what they do in these individuals, this is the early stages of this, is that they're getting different doses of the vaccine for amyloid, meaning that we're making a vaccine that attacks and turns on the immune system to kind of bind to the amyloid and suck it out. And so it's looking at individuals over different ages from about 35 to 50. They get a number of intramuscular injections. And as you can see, pardon me, that started in 2023. We've already recruited some individuals for this. There are other sites that are doing that. If individuals are interested, you're welcome to contact us and get evaluated for these kinds of studies. The second one, go on to the next slide, thank you. Pardon me, was the antisense oligonucleotide. So in this kind of study, what we had been doing was that we were actually doing a lumbar puncture, introducing this antisense oligonucleotide, meaning that it would bind to this protein, prevent the amyloid from being made, and because of that, more of it would be cleared and it wouldn't deposit within the brain. We were the first and only site that did this study. However, the study has currently stopped right now. A third one, if you go to the next slide, is something that's going to be coming very soon. This is called the Aladdin study that's using a drug called donanemab, which is a drug that's actually approved by the FDA for late onset Alzheimer's disease. So this is a phase 4 study. In this case, individuals will get an IV therapy every 4 weeks, and we'll be evaluating by taking repeated MRIs and PET scans to see if there's a drop in this amyloid that's present. This has not yet started. We're hoping either later this year or the beginning of next year for this study to really start. So if you go to the next slide. So what I kind of do is tell you these take-home messages that Down syndrome, Alzheimer's disease, is a genetic form of Alzheimer's disease. AD, in this case, has nearly full penetrance. There are ways that now that we can make a diagnosis for amyloid tau and neurodegeneration. So seeing these changes in vivo, meaning as in individuals that are living, there are differences and similarities with these different genetic forms, as well as they can teach us what's occurring in late onset Alzheimer's disease, and that this may influence what kind of clinical trials that we're thinking about. And that really this is the ideal population to look at both very early on, as well as when individuals, before they become truly symptomatic with the disease, we can start to intervene with these therapies. So if you go to the next slide, it's just it's not just me, it's really a team that we're really working with. You can see this great team that we have here. I've just highlighted Brittany Nelson because she's our lead coordinator, who's really been doing all these kinds of studies. And you can see we have strong collaborations with large number of groups, but more importantly, we want to thank all of our participants for being involved in these studies. If you go to the next slide, this is us being active in our community. Active in our community and what we do with our community and while we give back to our community, and we're very invested and really want to work and partner with anybody. And we're also willing to take individuals from other places if they want to come, stay, get evaluated by our site and do these kinds of things. We're glad to do that. And then the last slide is ways that you can contact Brittany, who's our lead coordinator in doing these kinds of things. And if you're really interested, please contact us and I'll be glad to take your questions. Thank you so much and look forward to future discussions.
Thank you so much, Dr. Ansis. And just let everybody know that if you have a question, please put it in the Q&A, not in the chat. We're going through and we will definitely direct your questions to the panelists. So at this point in time, I want to call upon Margot.
Thank you so much. Hi, everybody. It's an honor to be able to speak with you tonight. My name is Margot Rondeau, and I got a new title today, which is I'm now the Vice President of Programs at the National Down Syndrome Society. I also am a mother to a 7-year-old daughter with Down syndrome. I'm not sure how many viewers on this webinar saw the big NDSS update today, if you're on our email list or on social media. But today it was announced that Lumine IDSC merged into NDSS, which is going to be able to expand our focus on accelerating research. Together, we are creating a world where individuals with Down syndrome thrive. So we're very excited about that announcement and opportunity. And if you want to learn more, you can go to our website. Next slide, please. Sorry, that's our old mission statement as of yesterday, but next slide. So at NDSS, we have 4 pillars. Again, I need to update this slide for how we support and advocate for individuals with Down syndrome. So we create resources and support, advocacy, policy, community engagement, and now also research is our new pillar. Next slide. When NTG asked me to be on this panel to represent the Down syndrome community and caregivers, I wanted to really think about the ways in which Alzheimer's disease affects our community differently than the general population, and what are the really sort of important things for you to know. So one of the biggest things is that the caregivers of people with Down syndrome and Alzheimer's disease are fundamentally different than the caregivers of people who just have Alzheimer's disease. The majority of the caregivers end up being parents or siblings, and I'm sure we can all on this call agree that having an 85-year-old parent care for a 50-year-old child with Down syndrome and Alzheimer's disease is really not ideal. So oftentimes a sibling, if they're available, will step in to assist, but often these siblings are coming in with really little information or support on how to care for somebody with DSAD. And many times they don't even know how to really care for somebody with Down syndrome. A lot of time we find that parents want to shield the siblings about the reality of caregiving and don't want them to feel a burden. So it is a really, really large learning curve that they get when they step in. So because of that, NDSS, and because of a lot of reasons, actually, NDSS created a series of guidebooks that we have. They're free on our website and to really help people along the journey. Actually, they're from birth to end of life. So the journey of just raising somebody with Down syndrome or caregiving for somebody with Down syndrome. 2 years ago, we updated the Aging and Down Syndrome Guidebook, which is the small one in the top left. And when we updated that one is just about what does it mean for to age with Down syndrome. We're learning a lot about that, given that the expanded life expectancy. So what do you need to know about that? And then we also created a caregiving guidebook that's about what you as a caregiver needs to know about yourself while your loved one with Down syndrome ages, and then a guidebook about how to prepare for end of life, which is nobody's favorite topic, but really an important topic to talk about. The large one on the screen is obviously the Alzheimer's disease guidebook that we have. We are going to update it in 2026. but it really walks through the stages of Alzheimer's disease, what it looks like, the stages your loved one will experience, how you can care for them, how you can modify things for them, but basically everything you need to know. Like I said, we're going to update that next year. We also have 321 Go, which is a program that NDSS developed to help increase the quality of life for individuals with Down syndrome by teaching essential lessons around physical activity, balanced nutrition, emotional wellness, independence, goal setting, and behavior change. It includes many of the modifiable risk factors for Alzheimer's disease. And while these risk factors have not been really researched as much in individuals with Down syndrome, it's still really important to take care of your body, your brain, your emotions. And I know Dr. Chacoin is going to touch on that a little later. Next slide, please. So another way that there's just a really big difference between our community and the general population is really the lack of awareness of how Alzheimer's disease affects people with Down syndrome by policymakers, and the lack of intentional inclusion in bills and regulatory rules, which I think is just because of lack of awareness. So last year, NDSS worked with Congress to pass the NAPA reauthorization bill, which included the words Down syndrome. And one thing I think is really amazing is it's the second time in the history of the United States that Down syndrome is written into federal statute. So we took that as a really big win. It also acknowledges the impact of Alzheimer's disease on individuals with Down syndrome and includes a seat at the NAPA Council for a population that is severely underrepresented that experiences Alzheimer's at a markedly higher rate than the general public, which is basically us. So we're hoping that we can really get a seat at the table to help with the council. We've also worked with CMS to ensure equality in coverage for the therapies and with FDA to create a pathway for therapies. Next slide, please. So another way that our community is different is the lack of inclusion in clinical trials. And as Bo mentioned, I want to really emphasize that this is changing. There are more clinical trials and we're hopefully more on the way. But with Lumine merging into NDSS, we're really able to approach this part a lot more holistically. So one thing that we found out, or we're in the process of finding out, is that people are not as eager to sign up for a clinical trial as one would think. And a lot of this is just hesitancy, history of Down syndrome in research, and I think lack of awareness on caregivers. And again, if it's an 80-year-old caregiver, 85-year-old caregiver caring for a 50-year-old, it's really difficult for them to be able to drive around and get to all the places that they need to be. So part of our new approach is going to be really to understand what this hesitancy is, to change this hesitancy by shifting mindsets and to work with research. We're already doing this. We already work with Dr. Ansets, but work with researchers to really help them understand people with Down syndrome and ensure people with Down syndrome are part of their advisory boards. And we're part of a lot of the groups that were mentioned previously, which is great. We just want to keep expanding as much as possible. Next slide, please. The other thing is that we really experience is a lack of awareness among physicians on how to accurately diagnose Alzheimer's disease in people with Down syndrome. So Dr. Chacoin will speak next, and I don't want to steal his thunder because he's the clinician, but we hear from families all over the country all the time about how doctors are misdiagnosing their loved one. Either sometimes it's too early, sometimes it's too late, sometimes it's just not at all. There are tools available. NTG has a really amazing tool, but to help bridge this gap, NDSS next month is launching a new initiative called Care Down Syndrome. So in partnership with Dr. Chacoin and 40 other experts, Care Down Syndrome is an educational hub for providers to learn about the healthcare needs of adults with Down syndrome, including Alzheimer's disease, along with all of the resources out there in terms of diagnosing and caring. And I'm probably overpromising, but it's great, and you can find what you need next month. Next slide. So before I turn this over, and I'm going to try not to get emotional, but before I turn this over, I just want to say one last thing, which is the majority of individuals in our community of parents, especially parents of older people, they're aware that their child, their brother, their sister, loved one with Down syndrome is going to get Alzheimer's disease because the rates are so high. And it is honestly everybody's worst nightmare. Like, no one on this call would want to imagine looking at your child and saying, this is what the last years of your life is going to look like. And other than signing up for a clinical trial, there's not really a lot we can do to stop it. This is the reality. And I just want everyone on this call to know that if you're the one delivering the diagnosis, if you're part of a study, if you're a practitioner, if you're a care provider, to please just take care when you speak about this topic, because you may be one day the person that has to tell a family that their worst nightmare is now their reality. And I know that that's a really, really hard thing to do, but it's even harder to hear that that your worst nightmare is here and this is what's going to happen. So I just ask that you please do so with respect and kindness. And with that, I'm going to turn it over. Thank you.
Thank you so much, Margot. And I am now going to call upon Dr. Largent.
I am so happy to be here with everybody speaking tonight, and I'll be speaking from a bioethics perspective. Next slide, please. So I want to say this is an area where there are so many ethical issues, and they're related to a host of things that have already been discussed by Margot and Dr. Ansis, right? Biomarker testing and sharing those results with families and patients, decisions around whether or not to pursue treatment or participation in research, as well as coverage of therapies, secondary prevention or trying to really intercede before the onset of overt symptoms, and more. So my goal today is to say a lot about a little, a little about a lot of things. So just touching on them, and I'm happy to dive into any of these issues or others that may be of concern to you in more depth during the Q&A. Next slide, please. So one of the things I want to share, and this bridges nicely from some of the prior comments, is that to date, what we know about sharing biomarker results or genetic testing results with individuals really comes out of piggybacking on clinical trials. So investigators like myself have partnered with trialists who need to know whether or not people have amyloid or tau or ApoE, what their genotype is, to participate in research. And then what they've done is they've studied the effects of returning those results within the clinical trials. And the limitation of that is that these studies have not been representative of the people who bear the burden of Alzheimer's disease, right? They tend to be white, well-educated, have a family history, and really don't represent or include people who have Down syndrome. So that's a big limitation I want to put over the next couple of slides, is that these results might not generalize. Next slide, please. What we do know so far, though, is that there early on were some people who were very adamantly opposed to giving biomarker results back to individuals, particularly those who were at risk for but had not yet developed cognitive impairment. And the two big objections that they gave to returning results to those individuals who were at risk was that it would be unsafe to share, that people would experience depression, anxiety, or suicidality, and that they just wouldn't understand the results, right? That it's just too hard to understand something that isn't 100% certain, but just is sort of about risk generally. But what we've done through these studies where we've actually looked and followed people is that we've learned that it is safe. People do not experience that anxiety, depression, or suicidality, and they do understand their results. So those are two good answers to these questions that early on were barriers to sharing. And I think we're moving forward in the field to trying to take in a more complex understanding of the sharing that can happen. Next slide, please. One of the things we've heard from individuals when we talk to them, and I focused primarily on people who are at risk and not yet experiencing cognitive symptoms, is that learning these test results are different than learning other medical test results. Next slide, please. And they really identify this in a few different ways. One is that it's distinct for their sense of self. We had somebody tell us, what a colonoscopy isn't going to change who I am, but developing dementia would in fact change who I am in some meaningful way. They talked about implications for their interpersonal relationships, that people would treat them differently if they were to share this information or experience cognitive impairment. They talked about the uncertainty of the information. They didn't know when they would become sick or what that sort of illness trajectory would look like. And excuse me, they also talked about the lack of medical actionability, this feeling that there really wasn't anything medically that they could do. I will say that many people are incentivized or desire to participate in research because of the opportunity that they might receive a drug or an intervention that would be helpful to them, or because it would help identify that intervention that would help people like them in the future. And so that's an important thing to think about. I will say that these results were collected you just move ahead, there's an animation. It was before the approval of some of the monoclonal antibodies. And so I think this answer might be starting to change. Next slide, please. People were very worried about stigma and discrimination. They talked about this in 4 key areas that I'll just highlight briefly here. One, in relationships, as I mentioned, that people would treat them differently. And they also worried about it in the workplace, that they would be overlooked for promotions, that they would be forced into early retirement, things like that would happen. In insurance, especially life, long-term care, and disability, if the insurer were to know they were at risk for developing Alzheimer's disease. And also in housing, there was a lot of worry that if you needed to live in a long-term care facility or a continuing care community, that they would be reluctant to accept you as a resident if they knew that you were at increased risk for developing dementia caused by Alzheimer's disease. Next slide, please. Now, while people said that there wasn't anything medically actionable, right, when we shared these results, there was not a drug that they could take that would prevent the onset of cognitive impairment, they still told us that learning this information could be very personally empowering. Next slide, please. And what we saw is that they really did change 2 different areas. They changed their health behaviors, oftentimes to make lifestyle changes that could promote brain health. So people talked about exercising more, eating more fish, getting better sleep, engaging in brain games and other cognitive stimulation, staying socially engaged. And we also saw people who are increased risk say they were making changes to their future plans. So they accelerated doing things that would bring meaning to their life or pleasure. They also engaged in a lot of pre-planning, so thinking about who would be their care partner if they were to develop cognitive impairment caused by Alzheimer's disease, thinking about updating their end-of-life plans, which I know Margot mentioned, and thinking about other legal planning that would need to happen. Next slide. One of the questions that really motivated me as well is that this information is not just given to an individual, right? It's the individual's result, but it really is going into a family system. And so I've studied how family members react to learning these results. And what we've seen is that the family members' reactions often closely parallel those of the older adult who's receiving the biomarker result. Next slide, please. So they have their own emotional reactions. They tend to be relieved if these biomarkers aren't present. They tend to be worried if they are present. They change their own health behaviors. If they know that their family member is at increased risk, often saying that they need to be in better health so that they can step into that care provider role. And they change their own future plans, really accounting for this possibility of being a care partner for somebody who's living with Alzheimer's disease. The other thing we see is that care partners will start engaging in more monitoring of the individual. So really starting to watch and wonder, is what I'm seeing normal aging or just the kind of lapse in memory that happens to all of us? Or is this how it starts? Is this how it begins? So there is kind of this self-monitoring that happens and also monitoring by care partners. But I think change is the lived experience of both individuals and their family members once they get these biomarker results. Next slide, please. Based on what we know about how individuals react to learning these results with colleagues, I've put forward this sort of 5-step process for thinking about biomarker disclosure. We recommend determining the appropriateness of testing and also making sure that the individual is appropriate. Some people don't want to know. Some people will share that they would be so distressed that the clinician might decide that they're actually not a good candidate. Then it's about providing pre-test education so that people really understand what the test can and can't do for us right now, as well as how the results might be used for them, whether in research or clinically, administering the test, returning the results with a pause between so that individuals can change their mind if they don't want to know, and then checking in and following up as needed. And with that follow-up, including either routing people into care that's appropriate for them or into research opportunities. Next slide, please. In terms of the anti-amyloid therapies that are now available to individuals who have mild cognitive impairment or early stage of dementia, I want to say that this is very much a preference sensitive decision. What we are seeing is that individuals who come and see us in clinic are really going through their own weighing of the perceived risks and benefits of treatment. And so for some people, they feel like it's really worth trying and they're not so worried about some of the brain bleeding or swelling that's been associated with these drugs, whereas other people feel like the burden of the regular infusions, the monitoring MRIs, and the risks, they don't think that's worth that. So I think we really have to respect and understand that individuals will bring their own values and interests to it, and we should respect those decisions. Next slide, please. I do think this is an area where we have to be mindful, thinking about individuals with Down syndrome, that there's a potential for provider bias in this decision-making, as in decision-making generally, right? Questions and perceptions about what is a fate worse than death, when is a life worth living, and to really guard against that kind of ableism and bias. When faced with a fatal disease like Alzheimer's disease, people with Down syndrome, I would argue strenuously, should really be allowed to weigh the risks and benefits of treatment for themselves and in conjunction with their families. This is an idea in the ethics literature sometimes referred to as the dignity of risk. Providers can have this impulse that's understandable to really try to protect the individual or maybe keep them from doing something that's perceived as inappropriate or risky. But there's also a dignity to respecting what an individual wants to do and how they see their own life plans unfolding. So I think that decision-making piece really should be squarely given, not to the individual with Down syndrome and their family. And for individuals who might have marginal decision-making capacity, we can support their decision-making abilities, accommodating them to, with help from a trusted other, that will allow them to make their own informed, authentic, and voluntary choice. And those are really the things in ethics we look for in a decision. We want people to understand what they're deciding. We want to make sure it's consistent with their values, and we want to make sure that that is a freely made decision. Next slide, please. I think coverage of these drugs is going to continue to be debated given the very high costs. Next slide, please. And just to offer a little bit of context and something I found so admirable, in January of 2022, CMS issued a national coverage determination proposal in which they would have excluded patients with any other neurologic or medical condition that could significantly contribute to cognitive decline from coverage of anti-amyloid therapies. And what that language would have done effectively is bar coverage for individuals with Down syndrome. And that's really notable, of course, right, given both the high rates of Alzheimer's disease and also the widespread eligibility of those individuals for Medicare. Next slide, please. So CMS, after it puts out a national coverage determination, has a public comment period. There were more than 10,000 public comments that were submitted. With a team of research assistants and colleagues, we read all 10,000 of those, and we found that more than 1,000 of the public comments came from people who identified as family members and caregivers for people with Down syndrome. And they were responding really directly to that criteria that would have excluded people who had other neurological conditions from receiving coverage. Across those 1,000 comments, there was near unanimous agreement that barriers to access for people with Down syndrome was discriminatory and unjust. And in that case, it really did result in meaningful change. In issuing its final coverage determination, CMS noted explicitly that it was changing the final rule to reflect those public comments. And so I think that the advocacy is really to be applauded here for achieving something that's important in terms of enabling coverage, enabling research, and really making sure that people with Down syndrome were not excluded from receiving these therapies. Next slide, please. And finally, as I wrap up and pass the reins to the next speaker, I just want to note that if a drug is approved for secondary prevention specifically, right, so for individuals who have biomarkers but don't yet have overt cognitive symptoms, and it's adopted into clinical practice, right, these are studies that are ongoing, but if it is successful and if they're adopted in clinical practice, I think that's just going to be an area of huge ethical controversy and one that we will have to continue addressing. And that's because it challenges both traditionally accepted ideas of who is a patient and also raises concerns about when it's acceptable to offer expensive and potentially risky drugs to individuals who at least, on the face of things are still healthy. So I look forward to the Q&A. Thank you so much for the opportunity to be here this evening.
Yeah, thank you, Dr. Largent. And last but not least, Dr. Chicoine.
Thank you very much. I really appreciate the opportunity to be here this evening. You can hear me okay?
Yes.
Great. Fantastic. Okay, so I'm going to kind of look at this like we're going to take all that thorough information that we've just heard and And then how do we use that in the clinical setting? How do we use that in patient care? So I'm going to really kind of look at the clinical aspects of these biomarkers. Next slide. As some I may know me, but I'm Brian Chicoine. I'm the medical director of the Advocate Medical Group Adult Down Syndrome Center in the Chicago suburbs. And we opened in 1992 when you've had the privilege of seeing over 6,000 adolescents and adults with Down syndrome. And so have unfortunately had the opportunity to see many people develop Alzheimer's disease over the years. Next slide. So as Dr. Ansis said, people with Down syndrome are living longer and healthier than any other time in the past. Next slide. And this is the curve I use in life expectancy. And I use those 3 dates because in 1907 was when my great uncle Leo was born. He had Down syndrome, although that's not what they called it at the time, of course. But and it's interesting, his life expectancy was about 9, although he ended up living to be about 40, which was very unusual in those days. The median life expectancy for a child with Down syndrome in those days was 2, meaning about roughly half the children died before age 2, and that was primarily due to congenital heart disease, which is about 50% of children with Down syndrome are born with. Presumably, Leo did not have congenital heart disease, but we don't know that for sure. But that's a safe bet. And then when I graduated from medical school in 1984, the life expectancy of people with Down syndrome was 28 or 30, and now it's about 60. And so, it's been very interesting for me. I don't take credit for it. I think that being able to treat congenital heart disease plays a big role in that, as well as other healthcare issues, moving people out of large institutions, all have really impacted since the 70s and 80s, the increased life expectancy. But it's been very interesting as to have a physician and myself as during their career where their patient population doubled their life expectancy. So that I don't know that that's certainly something very common you see in medicine, but it's been very interesting to see all these people that are now living longer. And the upside to that is obvious, but the downside, unfortunately, is that now we're seeing these people live long enough. These folks with Down syndrome live long enough many of them, unfortunately, to develop Alzheimer's disease. And so there's a study that suggests that curve now has leveled off and it's no longer going up like that. And again, Alzheimer's seems to be the big issue for, sort of capping the life expectancy average at about 60. And hopefully we'll see that change in the coming years. Next slide. So as Dr. Ansis mentioned, there's certainly, I just want to run through the symptoms again. We see, and several studies indicate that very commonly the first symptoms, not always, but commonly the first symptoms are psychological changes or personality changes. We often see a change in the common behavior of self-talk or a change in their adherence to routines. Obviously, there's memory impairment, loss of previously mastered skills. Ultimately, as the disease progresses, incontinence, weight loss can be it sometimes actually be an earlier sign of subtle weight loss changes or weight loss changes in weight. And then seizures, unfortunately, are at a significantly higher rate in people with Down syndrome who develop Alzheimer's disease versus people without Down syndrome who develop Alzheimer's disease. And then unsteady gait is a common thing. And then ultimately, swallowing difficulties. And in our experience, that is often what we would call the beginning of the terminal event, where people start to develop aspiration pneumonias due to their swallowing difficulties, and very commonly that's the ultimate cause of death as the disease progresses, unfortunately. Next slide. So again, it was shared that the prevalence is maybe as high as 95% lifetime, 95%. Estimates vary, different studies over the course of time. Perhaps 55% in those aged 50 to 59, greater than 75% in those aged 60 and older. Really, I think the data is still being sorted, but I think the unfortunate reality is that it's just very common, in people with Down syndrome, as has been pointed out. Average age of diagnosis in the mid-50s, and then average age of death, studies suggest in the late 50s to early 60s, which again, as Dr. Ansis indicated, that the decline tends to be more rapid in people with Down syndrome who develop Alzheimer's disease compared to people without Down syndrome who develop Alzheimer's. Next slide. So more specifically with biomarkers, and I'm not going to go into the detail that Dr. Ansis did, first off, because he's already done it, and secondly, because I don't understand it the way he does. But this is some data from a study we were part of with the Lumine and with Life DSR, and the specifics, there may be a little variation in different studies, but I think that the general concepts I think are the same. And so this would be just a sort of a general view of some of the biomarkers that tend to go up, particularly around that age 40, 45, which Dr. Ansis had commented was pretty much a time when almost universally people with Down syndrome have developed the changes in the brain, and then the one biomarker that goes down around that time. Next slide. So, clinically, what I'm really looking for and hoping for is what comes in the coming days, is a more objective measure to improve our diagnostic accuracy. So right now we do rely heavily on the history and as well as neuropsychological testing, and which the testing that would be done for someone without Down syndrome to assess for Alzheimer's is really not appropriate for people with Down syndrome, and it can be challenging to find someone who really is able to do the testing, neuropsych testing that's more specific to a person with Down syndrome or intellectual disability. And so really having a more objective measure that gives us an idea that, I'm visualizing a panel of biomarkers at some point, hopefully blood, obviously lumbar puncture is very important in the studies, but hopefully we can ultimately, get this to be done in the blood work. And so that you would say that, this has now gone up X% or whatever, or out of this range, and that's considered abnormal and consistent with Alzheimer's disease. So hopefully that day is coming. At least from talking to Dr. Ansis and others, it sounds like we're not too far from that. Next slide. I think it's still going to be very important that again, if you consider the fact that almost Alzheimer's disease is almost essentially universal in people with Down syndrome as they get older, unfortunately. So even if the curves are going up or going down in the case of the one, it's still going to be important to make sure that we look for other things that are either not contributing to the decline or the physical, the symptom change, or that they actually are coexisting. So there may be possible that someone has Alzheimer's disease and something else, and we want to make sure that we look at those other possibilities. So for many, many years, anybody with Down syndrome that declined, it was often attributed to Alzheimer's disease. And I can't tell you how the literally dozens and dozens of phone calls really from all over the world we've gotten. My 20-year-old son with Down syndrome has been diagnosed with Alzheimer's disease because he's had a decline in skills. And so we're still going to, obviously that, I've learned, as I say, I learned never to say never in medicine, but that's really pretty much a never. And so, to develop it at that young age. And so, really, we want to make sure that we're looking at not just assuming that someone with Down syndrome is, because they're declining, has Alzheimer's disease, because there's lots of other reasons that people can decline, and many of them are very treatable. Alzheimer's disease ultimately will be treatable, I believe, but many things are very treatable now, whether it's a vitamin B12 deficiency, thyroid problems, depression, all sorts of things that can look very similar to Alzheimer's disease, but for which we have better treatments at this point, even as now compared to Alzheimer's disease. So really, it's very important, no matter how else all this shakes out, that every decline in skills is not Alzheimer's disease. And so if you take anything away from my talk, I would take that. I think that's very important to consider, even as we get better diagnostic capabilities going forward with the biomarkers. Next slide. So again, Alzheimer's disease is really, I think it'll become much more a diagnosis of blood work and of markers and other, diagnostic testing, PET scans and things as we go forward. But again, I think we're still going to want to consider the possibility that other things may also be contributing to the individual's decline. So very important to consider these other possibilities, even if we make a definitive diagnosis of Alzheimer's disease, because there's no rule that a person can't have more than one thing. And so, and there are many possible reasons that can cause a person with Down syndrome to display cognitive and psychological changes. And so we're going to have to continue to consider those even as we move forward from with having such better objective measures of diagnosing Alzheimer's disease in the coming years. Next slide. So as Dr. Largent was talking about, what about the folks that don't have symptoms and but may be beginning to have those changes in the biomarkers and which would hopefully as the studies will show will coincide with changes in the brain. And so what do we do with those folks? So my hope as we go forward here will be that there will be treatments. Maybe, hopefully, there's Dr. Largent talked about the ethics of very expensive medications with some significant side effects. But hopefully, as we go forward, we will find that there are, this may be a multi-step approach. So, in an approach where the diagnosis is made and the markers are clearly going up, there may be one treatment, and then at this stage, there may be a different treatment. It may be, we're learning more and more about. Certainly in the non-Down syndrome population, and people are really beginning to look at this in the Down syndrome population as well. Things like more simpler things, we'll call it exercise, healthy eating, good sleep. Treating sleep apnea, which we know increases the burden of amyloid in the brains of people with Down syndrome, and so many things that hopefully we can use going forward. So. Perhaps someday we will, do these biomarkers at a younger age, and at this age we'll, say, okay, biomarkers are still good. Let's put in the extra effort to do the exercise or do whatever the things that we discover, and then later, if the biomarkers start to go up, now we may choose a different treatment to treat and hopefully prevent the biomarkers from going up, and at the same time prevent the progression of the disease. Next slide. And then ultimately, as Dr. Ansis pointed out, the changes in the brains of some of the folks with Down syndrome starts at a very young age. And I believe he showed a slide of somebody in their 20s or perhaps their 30s with these changes. So what about before people ever even develop some changes in the brain? What are they going to be able to do with that? And what will the biomarkers tell us about that potentially? And again, obviously, as Dr. Largent indicated, there are all sorts of ethical issues that we're going to have to make sure we're tackling as well, and not just the medical, strictly physical medical issues, the medication benefits and risks and whatnot, but what are the other ethical issues we're going to have to address with this? But I think, ultimately going forward, hopefully we will have, again, sort of a stepwise thing, and at this point, perhaps have something that is not as potentially toxic or has the side effects that some of the medications, at least for now, that we're looking at, would have in the later stages when people are actually symptomatic. So I'm really hoping that over time we will have a sort of an approach where at different times in life we're looking at potentially looking at the biomarkers and then addressing these in different ways depending on what the findings are with the biomarkers as well as the symptoms. And time will tell. And certainly that's not certainly with for example, people with diabetes, it's very common, even before they have any evidence of heart disease, that people are already very aggressively putting them on medications to prevent heart disease, even though they don't have any evidence of it at this time. So there's certainly lots of things that we approach in that way to prevent complications of different conditions, including, in this case, Down syndrome being so associated with Alzheimer's disease. Hopefully we'll be able to approach this stepwise in the coming years. Next slide. Whoop, go back one. There we go. So as Margot was talking about and others, I think it's irregardless of what happens with regardless, I guess, what happens with the biomarkers and all these treatments, there's still going to be some issues that we're going to have to continue to look at. And supporting individuals with Down syndrome and Alzheimer's disease is still going to be important. And again, as Margot pointed out, I always say this is really the one population with Alzheimer's disease that tends to be cared for by their parents, or in some cases their siblings, but their parents versus the rest of the population that is cared for typically by their children. So it's really a different ball of wax. And so not only looking at supporting individuals, but also their families. Next slide. So again, as we look at this, and we're still in process of learning a lot, and I think in the coming years, this is going to change hopefully dramatically. But there's still real need, particularly now, and I don't think this will go away in the future. Really focus on what a person can do and what they enjoy when they do develop Alzheimer's disease, rather than put all the focus on what they can't. I mean, it's important to address those things that they can't do, but really, what can they do, and how can we, enjoy those things and enjoy life to the best that we can. We certainly know from the non-Down syndrome population that social interaction is such a huge piece of probably even prevention of Alzheimer's disease or delaying Alzheimer's disease. And we don't have any specific data that says that's the case in people with Down syndrome, but certainly that, at this point, we don't have any data that says it isn't either. And so I think that's we want to continue this safe social interaction, safe being, if the person does have some impulsivity or loss of ability to understand safety, we want to make sure that we're keeping them from hurting themselves. But at the same time, we want to encourage people to be socially interactive, and hopefully that it will actually not only increase the quality of life, but also potentially even slow the disease, or even prevent the disease in some cases as we learn more, hopefully. And the other thing is we really want to optimize communication strategies. And again, as people decline, how do we need to change? How do we need to change those strategies, and how do we need to, keep people to do as much as they can for themselves as possible, and what tools can we use to do that? Next slide. And there are some great strategies. I love this guide from the Down Syndrome Scotland. So really some good information on living with dementia. Certainly there are some sensory strategies, some visuals, home safety and adaptive equipment. All the things that we can do to try to, again, to just help people to continue to function as well as they can for as long as they can. Next slide. And then again, all the other things we can do. So no matter what else we learn from the medications and the screening and all those things, I think it's still going to be important that we continue to look at all those things that, we don't know specifically all the relationship between these and Alzheimer's disease and people with Down syndrome, but we're learning more about some more about this in Down syndrome, but certainly more about this in the non-Down syndrome population. All the other things to do that we can do to help keep people healthy and function as well as possible for as long as possible. Healthy eating, physical activity, recreational activities, good sleep, stress management, relationships, social interaction, as I mentioned, employment and vocational opportunities, good hydration. So all those things are still going to continue to be important as we learn more about diagnosing and treating Alzheimer's disease. Next slide. And then, as Margot said, it's so important, the caregiver support, and as Dr. Largent mentioned, this is even, if we're going to be doing biomarkers before symptoms, what is the implication for the family? What is the implication for the person with Down syndrome? What kind of support do they need for that? If the person is diagnosed, what kind of support do they need for that? So as I think Margot said, this isn't not, when this diagnosis is made or even before diagnosis is made, this is really a condition that affects the whole family, and it's so important to include them in not only in the process, but also in the support that we're able to reach out to them and help them as they go through these days. And I agree with Margot. I think there's a lot of, even without the biomarkers, there's a lot of families looking at what's going on around them and other people with Down syndrome developing Alzheimer's disease, and carrying that with them, and in their heart, knowing that this is a strong possibility. And so how do we help people deal with that? One of the things that I like the term Dr. Largent used was medically actionable, and I think we're really getting to the point, where when our clinic opened 33 years ago, we had really nothing to offer, but I think we're really learning a lot about lifestyle interventions, certainly medication possibilities, and then certainly research and participating in research, and what can we do to really get after this condition. Next slide. And then something that I find really interesting, and I don't think gets a lot of attention, is how other people with intellectual disabilities or Down syndrome are affected. And we know that certainly there are people with Down syndrome who live in homes or places where other people with intellectual disabilities or Down syndrome are affected, or they work with other people with intellectual disabilities or Down syndrome. And so and we do know that from our experience that these folks are affected when one of their friends or their coworkers is impacted with Alzheimer's disease. And so I think it's really important for that, we really share the message that it does impact these individuals, and they are aware, and they do see it, and some of them are afraid that it'll affect them, and some of them are just afraid how the person's decline is affecting their life now. It can certainly cause fear and anxiety. It can cause resentment. We've seen that where someone lives with someone with Down syndrome who developed Alzheimer's disease, and now that individual is not able to do their chores, for example, and it falls to the other person, and that can cause resentment. But on the upside, we have seen sometimes it bring out the best caregiver in people with Down syndrome or other intellectual disabilities that really do, in a sense, step up and really show a lot of compassion and care to the individual with Down syndrome who has developed Alzheimer's disease. So we actually have on our website some information about some stories for family members, friends, and roommates, and how how can you help address these changes and how it might impact on your life. Next slide. Next slide. So again, just to recap, as Dr. Keller mentioned, certainly the sponsor of this webinar, the National Task Group, great website, lots of great information. I encourage you to take a look at that, as Dr. Keller mentioned earlier in the presentation. Next slide. If you are a professional or you are a family member and want to reach out to your professional, the Down Syndrome Medical Interest Group has a lot of information for health professionals. Certainly membership. We have a speaker series, and then we have something called Project Echo, where it's not open to non-professionals, but it's where a healthcare professional can present a de-identified case to a panel of, it's usually 20 or 30 people, health professionals that care for a lot of people with Down syndrome, and we're able to then share our experience and knowledge with that healthcare professional so that he or she can better care for the individual with Down syndrome, particularly for health professionals that don't have as much experience or knowledge in caring for people with Down syndrome. Next slide. And then our clinic, we have an online resource library that has lots of information as well. Next slide. And then you can just kind of flip through the next few slides. Just if you're interested in reading some of the primary literature in medical journals, we've included some.
Thank you, Dr. Chicoine. Thank you very much. So before we move on to the questions from the participants, I'd like to just throw out to our panelists, and thank you to all of you. What a wonderful presentation from each and every one of you. And we've heard about research, we've heard about medical issues, we've heard things from family perspective and from bioethical perspective. So I just want to ask all of you if you could come up with one or two next steps for the family member or the stakeholder. What is your takeaway? One or two things that the person can next do to best advance care for the individual who is suspected of having dementia. Any of you?
I could start. I would say two things. One is, long before they get to having dementia, I would really go back and look at lifestyle issues. I think we're learning more, and I think for all of us, healthy eating, exercise, et cetera, that I talked about, I think is so important to really go back and look at that. It has so many implications for so many health issues, but we're learning probably has implications for Alzheimer's disease as well. And so I think that would be a starter. And then the second thing is, we're only going to learn more about how to address this with research. And so I would really encourage you to consider the possibility of getting involved in participating in some of the research that's going on.
Right.
Lucy,
Dr. Ansis? Yeah, go ahead, please.
No, I was just going to say, I totally agree with Dr. Chacoin. I think it depends on the age of your loved one. That I remember Dr. Head once told me that successful aging starts young. And so no matter what age your child or loved one is with Down syndrome, to start taking care of your body, your brain, and your emotions, and sign up for clinical trials, because that is how we're going to know what the best answer is to this question. If your loved one is diagnosed, you suspect that they do have Alzheimer's disease, then I would encourage people to try to find a physician. If you can't, you're welcome to email health@ndss.org, and we will try to help you and connect you with our local communities. But I would also just really urge caregivers or people working with caregivers to find support for yourself. It is exhausting. It is hard. And it is not something somebody can do 24/7. And caregivers are really going to need help in the process of supporting their loved one.
Absolutely. Okay. Dr. Ansis, Dr. Largent, did either of you have anything else to add before we go on to the questions?
Yeah, I think I would join in with Dr. Chacoin and Margot, what they were just discussing. There are some reversible causes, and we've seen with sleep apnea and evaluations and exercise, healthy diets, they do make a difference. We're even seeing that in, as you were hearing, in late onset Alzheimer's disease. There's been a more recent study called the Pointer study that has shown some benefit. And loneliness definitely makes a difference. I think one of the biggest things that was toughest is, of course, COVID, and how many people and services were lost because of that, and those interactions that were missing. And then I would really try to team up and find individuals and physicians who are willing to see. I know that's very tough. We need to really increase that and really need to meet that demand. But it's been very interesting to see patients, they kind of graduate from 18 to 20 years old, and then all of a sudden they're not really followed up or seen, and then all of a sudden they're coming with thinking problems. And so at a much later age, and really to engage your primary care physician and work with him or her, and then figure out, because because of these research studies, we are going to have better biomarkers and better ways to make a diagnosis, as well as potential therapies for these individuals. So I think it's a really heady time, but there are serious consequences that are doing that. And then the final thing is, I tell family members, as you said, take the time off. You need respite too. It's a team. It's a really team environment, and I'm very strong for those teams and those people, and they need to also be as strong as they can be. And so they take some of the time off. That's very important.
Thank you. I think we're going to move on to the questions, and I just want to tell participants that if we don't get to your question, we will definitely be sending them to the relevant panel member, and we will make sure that you get an answer to your question. So I'm going to start reading. And hi, Janet. So this is a question for Margot. Has NDSS connected with the sibling leadership network to those booklets into the hand and put those booklets into the hands of SIBs? And has NDSS connected with Anchor or the National Association of Direct Support Professionals, so provider agencies and DSPs have access to this information?
Thank you. That's a wonderful question. I want to say maybe a little bit. It's always a great reminder of other groups to reach out to. And so if anybody on this call has other ideas of people that we can reach out to share information, please don't hesitate. Again, our email is health@ndss.org. And we love connections, and we love these resources are meant to be free and helpful. So the more people we can get them to, the better.
It's great. And Jillian Erdman writes, are any of the functional medicine lifestyle adaptations and precision medicine testing being piloted by Dr. Bredesen and Dr. Ornish in the general population being offered in some of the research for those with Down syndrome?
Not right at this time. We are looking at lifestyle modifications. We are looking at people, and we're actually doing a number of different ways or devices to measure stuff in individuals, including actigraphy and other ways to look at that. As for specifically clinical trials for this and doing that, that is not yet been doing, but that is Dr. Segan Hartley and others in Wisconsin are considering and thinking about kinds of exercise or other kinds of interventions to do that. So there is consideration for that in the future, at least on the research side.
And we have Eileen Devlin asking, how do you discover biomarkers? Who does this?
I can try to take it. So first of all, just to make sure we're understanding. So a biomarker is a way that we look at and gives us a kind of a picture of what's occurring in the body. It's a kind of marker or tag of these kinds of changes that are developing in an individual. And so, you know, the classic, the gold standard was to always do it at pathology and to look at those kinds of changes in the brain. And we can't do that when I never want anybody to have a biopsy. So are there other ways that we can look at those kinds of measures? And so there have been ways to look at it through imaging and also through this mechanism called a lumbar puncture. So look at the spinal fluid, the fluid that surrounds the brain. I kind of tell people that's almost looking like we're archaeologists or looking at the trash or what's happening in the brain. And that gives us an idea of what's actually occurring in the brain cells. And so looking at it that way, and then more recently, now there have been blood tests that have been developed. And as many of you have been discussing, that is really the wave of the future, so that we now have a way to kind of look at that. And Dr. Chicoine beautifully showed some of those results of some of that study. And then there have been other studies that have also looked at that. So there's really a heady time. We didn't have that even 5 years ago. The blood studies never existed. And the ability to do that and make it more available to everybody is what's something we're really trying to do.
There's a question. Thank you. There is a question. Okay, I just lost it. But it had to do with helping people tolerate getting shots, or, you know, being able to tolerate the procedures that would be involved in participating in any of these studies.
Yeah, so we've done some of those videos, and we've actually worked with a number of groups, NDSS and other groups, to literally do that and walk through. And the most important thing is that we've had wonderful patient advocates who are doing this, who are also working with them and saying, I've gone through the same kind of experience, and then showing those kinds of videos, what it's like to go into have a pictures taken, what it's like to have a lumbar puncture and doing that kind of stuff and walking them through those procedures. It really makes a difference, because then they know that they're not alone. And then the other thing is, in some of these research studies, we're doing the siblings or the parents, and we're looking at those kinds of changes. And we can kind of say to them, look, you're going through this, and your parents or your brother or sister will be also going through this. So there's a kind of team bonding experience that's also going through.
Deborah Adler writes, are there any JAKs inhibitors being looked at for people with Down syndrome to slow down the amyloid buildup in the brain?
I'll answer that one too, but it was something that's very interesting that Dr. Chicoine was mentioning, which is very, very important in the field, is that, and this is not for this talk, but it is for the other ones, is regression syndrome. And we see that in younger individuals that may be having some of those changes at a younger age, that have also been told that they have Alzheimer's disease, which is probably not the case. They may have this regression syndrome. As was mentioned by Dr. Chicoine, this is a disease of exclusion, so we rule out everything else that is being done. And we kind of say, if it's not these other causes, then more likely it's regression syndrome. We don't have a biomarker or any way to test specifically for it. With regards to JAK-STAT, that is being considered, and there is a clinical trial that's being actually done, University of Colorado, that's looking at that versus 2 other medications for regression syndrome, but not for Alzheimer's disease at this time.
Thank you. Sarah Mann asks, how do you see how much tau proteins there are?
Yeah, a lot of questions are going to me. I want to be hogging up. The tau protein, we can look at it in 2 different ways. So one is through a PET scan, and we can actually inject, wait for a period of time and see if there's an uptake in the brain and look at tau in the brain. And then the second way we can do that, there's actually two other ways, is to look at something called the spinal fluid again and looking at tau measurements in the spinal fluid and see if they're also increasing, and you saw that. And then the third one was, as Dr. Chicoine was showing, and we've also looked at it, is this tau changes within the blood. And so any of those three ways are the ways that we're kind of looking at those tau changes that are occurring. And we think that those tau changes, again, are occurring much quicker, as well as closer to when the cognitive changes are also changing in these individuals.
I think I have two questions for Dr. Chicoine. One is, which type of physician would be able to cater to such patients? And the other one is, how do you feel about the use of Namenda for folks with Down syndrome?
I think it was Dr. Ansis mentioned the clinics and the multidisciplinary, and that's often really the benefit to, have a neurologist. I think I'm a family physician by training, so having a medical home, if you will, that you really can continue to get ongoing care, I think is an important piece. But oftentimes it really does involve multidisciplinary, maybe a psychologist or a social worker to assist. I think I would love to have Dr. Largent at our place to help address the ethical issues. So I think I think you really want to look at all those things if possible. And what was the second question? Sorry, as we're talking about Alzheimer's disease.
About Namenda.
Oh yeah, I'd love to hear what Dr. Ansis says, but in the studies that I read and our experience, I really have not found it to be of benefit in our experience. In fact, I found probably more frequently that it's changed someone from being happy and demented to angry and demented. And at least in our experience, we've had a lot of side effects from it. So we don't typically use it. Dr. Ansis, what's been your experience?
Yeah, it's not as, there have been some studies that have shown not that much benefit from it. It does have some GI side effects from it. And so that's been the major reason why we've been looking at other medications, including medications that are being used in late onset Alzheimer's disease. Those studies did not include Down syndrome individuals, so that's why we're doing those clinical trials right now. And that's been a major limitation. And I have to say, I apologize that that's an oversight that the companies and the trials have excluded adults with Down syndrome for that. And so that's why we're literally looking to see if these medications, rather than Namenda, can be of a benefit, as well as the vaccines. And then there are other kinds of therapies that are being considered in the future on the horizon as well.
Lucy, can I just add a comment to that?
Yes, please.
Hi, this is Sept Keller. I'm a neurologist, and I do treat in general practice of adult physicians. I think the key is if you're going to give any medication is to know how to assess the individuals. And I think one of the difficulties we have in treating people with Down syndrome and other forms of intellectual developmental disabilities in general practice is to know what kind of objective measurements can we tell that they're getting value or benefit from anything that we treat. Biomarkers, imaging the brain, that's true, but a lot of these dementia symptoms are very subjective. So I think one thing that we have to do in our general practice, both primary care and specialty care, is to know what are those measurements we can say. If you're going to give a Namenda or any of these drugs, just say you want to try it, how are you going to know it's working or not? And because these are not miraculous treatment. So I think that's one we have to know. If you're going to treat someone and try something, then you have to have an answer. Well, how are you going to know? And if you don't really know how you're going to follow it, then I'm not sure that's a safe bet. That's what I would say. And I think the only added comment I would make, and then I'll get off, is that we in both neurology, primary care, is that we have to do our job to make sure that our brethren who are the general practitioners and specialists who are going to be around the world, around the country, seeing these individuals, that they know what they're doing. So that really goes a lot to education and training, like we have on this update webinar right now, what we do. So we in neurology are working very internally with the American Academy of Neurology to try to teach and educate the general neurologists, and that would be the same for primary care. We have to get into the practices, otherwise everyone's going to go to their practitioner, and the practitioner is going to say, I don't know how to treat someone with Down syndrome. Or the memory center clinics, like in the National Task Group, we're very much involved in helping to work with the memory centers with the GUIDE program. So that's another story.
Yeah, thank you all so very much. It's a good note to end on, Dr. Keller. And I'm going to turn this over to Catherine to close us up in terms of the survey. And here you see information on the screen. I want to thank all our panelists for offering us excellent updates and a lot to think about. Thank you.
And again, I want to echo, thanking everyone. This has been incredibly informative and thought-provoking. So thank all of you, not just for participating in our webinar today, but what you do each and every day for the people we're here and so interested about. Those of you who want CMEs for attending today, you can either use your smartphone and click on that QR code, or if you wait until we end the webinar, you will see a screen pop up in your browser automatically with the survey. You must complete the survey to access your CMEs. That is a requirement of the folks who are providing our CMEs. I will also say that link to complete the survey and receive your CMEs is only going to be open for 48 hours. You have to have attended the live webinar. You can't watch the recording and do it. It is a requirement of, again, of the supplier of our CMEs that they are only for people who attended live. So just want to make sure everyone hears that clearly and there's no confusion. So please take a moment and complete the survey. It's very brief. Let us know how we did with it. Also, we do have a question about other topics that you might like to see us address in the future. And that information will be very valuable to us, and your feedback is important. So please complete the survey. Those of you who need CMEs, when you get to the end of the survey, you're going to be directed to a second page where you will click on a button. It will take you to your certificate. So with that, I will end and thank you all. Everyone have a great rest of your evening or afternoon, depending on where you sit on the face of the earth. And we look forward to seeing you next time. Thanks everyone so much.
Thank you.
Catherine, are we able to save the questions?
Yes.
Okay, good. Thank you.